The side nail is used frequently to stabilize fractures of the tibia. 110 degrees of flexion is necessary, and some people use a sterile bump, some people use an Alaska triangle, but whatever device you use, it's important that no pressure be placed on the popliteal vessels. Fractures of the proximal tibia are treated differently than fractures of the midshaft or the distal tibia. The proximal tibia fractures are usually within 6 inches from the joint. Often the proximal fragment will be anterior to the distal fragment. If that is the case, it's very important that a surgeon place their hands on the proximal fragment and cause reduction in 110 degrees of flexion. Look critically at the x-ray to be sure the proximal fragment is anterior to the distal fragment. If you put your hand here, you displace the fracture and your reamer will go out the back, which is a frequent problem. Since we have been placing pressure on the proximal fragment in the figure 4 position, we have had no reason to use blocking screws nor the suprapatellar approach to stabilizing fractures of the tibia. Fractures of the distal tibia and midshaft tibia are treated differently. Their gravity is necessary to effect reduction. The surgeon who is holding the reduction is the most important part of the team because he or she must analyze which way the fracture fragments are moving during the reduction. You can often feel some of the fractures. Closed reduction can be done within 7 to 10 days, but don't keep trying to do it if it's not working, because many times you can move the fracture site. It looks like you should be able to do a closed reduction, but there's just enough subluxation that it can't be accomplished. It's important after the reamer is thought to be in the distal fragment to assay the position of the reamer by allowing the reamer to go to the subchondral bone, and there should be a stop. If there is no stop, the reamer is not in the distal fragment, and you must try again. This is a very important aspect of closed reduction of the tibia. It's the same protocol when you're placing the nail through the fracture site into the distal fragment. By the way, the best way to measure the length of the nail is how far the reamer goes to the subchondral bone, and then you can take that distance as the size of the nail. The approach to the bony entrance is made through the patellar tendon. A longitudinal incision is made from the tibial tubercle to the patella. Be sure you extend your incision all the way to the patella. Do not violate the fat pad. The curved awl is used to make the entrance hole. Be sure you do not damage any structures of the knee, but go as proximally as possible. The bone entrance is made using the curved awl. Once you have penetrated the bone with the curved awl, slide the awl anteriorly to shape the hole so it will go as anteriorly as possible. The big concern about reaming and placing the nail through the tibia is misplacement of the reamers or nail out posteriorly. Once the bone entrance hole has been made, you're ready to ream. The pointed reamers are used to direct the tract from the metaphysis to the canal of the tibia. Gradually increase the size of the reamers used so that you're using the blunt reamer, and listen for chatter or feel the chatter for about 4 centimeters of the tibia. That's the diameter of the nail to use. The length can be measured by placing the reamer, again, the blunt nose reamer, down to the subchondral bone. This will indicate how long the nail should be. As you withdraw the reamer, save the bone each time for use in placing it at the fracture site. This, of course, is only applicable if you do an open reduction. Setting up the target arm with the nail is shown in the antegrade approach to the femur. Once the nail is set up, please observe where the bend of the nail is. The bend of the nail, when used to treat tibia fractures, should be apex posteriorly. I remind you again to go slowly and use hand pressure and rotation as the nail is advanced. Sometimes it's necessary to use a mallet. It's very important to use the tissue protector to keep the nail off the bone. It's also very important to have 100 degrees of flexion, and you can visualize if you have less than 100 degrees of flexion that the patella will push the nail posteriorly. That amount of flexion is necessary. Another point to make is as the nail is advancing, the foot should be stabilized on the operating table to avoid distraction of the fracture. Using the tissue protector is very important to avoid having the nail hit the skin. The skin is what harbors the bacteria, which can cause infection. Sometimes it's necessary to use a mallet when advancing the nail, and if so, be sure to use rotation. Placement of the distal interlocking screw is illustrated in the antegrade approach to the femur as well as the animated video. The tibia itself has an unusual situation in that the isthmus may direct the nail more anteriorly. If the nail is directed more anteriorly, sometimes the target arm, which is set up for a straight nail, will direct the alignment pin and thereby the cannula more posteriorly. If this happens, loosen the adjustment screw and then tighten it so the alignment pin will direct the cannula to make the hole in the bone. Once the distal interlock is accomplished, compress the fracture site. I like to compress the fracture site after the first screw has been placed because it will tighten up with the second screw. Proximal interlocking screw placement is the same as described in the antegrade approach to the femur and the animated video. Remember that the drill goes through two cortices, the slot finders are not used, the step drill enlarges the hole, measurement is made, and the screw inserted. I suggest if you are placing the distal interlocking screws in the metaphysis and the proximal interlocking screws will be placed in the metaphysis, that 2 screws be used. This will allow the patient to begin walking early. Once the proximal interlocking screws have been placed, close the incision. Be sure to take small bites of the patella tendon, maybe only 3 small bites so you don't devascularize the tendon. Close the skin and the patient should be allowed to walk on crutches the next day. What's very important in every sign surgery is to remember to manipulate the knee at the end of the surgery. This manipulation is done very slowly, and sometimes you hold it as long as 1 minute before advancing. The goal of manipulation is to stretch the tissues rather than rupture them.